Hello, my name is Professor Isabelle Recoca. I'm medical oncologist at the Centre Léon Bérard and a professor at the University Claude Bernard Lyon in France. Today, I will sharing my interpretation of clinical data presented at this year's SGO Hybrid Annual Meeting on Women's Cancer, with a focus on PARP inhibitor as the first-line maintenance therapy for patients with advanced ovarian cancer. This activity will be identified in three parts. The first one, we will look at the efficacy on PARP inhibitor in the management of ovarian cancer. The second part will be dedicated to safety data. And the last one is how we can use this new data in our routine practice to manage our patients with ovarian cancer in first line. The last question about the efficacy on PARP inhibitor in a first-line maintenance setting is coming from 2 years ago, 3 years now, where we have seen several big, large randomized phase 3 trial reporting the activity of PARP inhibitor alone or in combination with BEV in the first-line maintenance setting for patients who are in partial or complete response after the first-line platinum-based chemotherapy. The PRIMA trial using the niraparib report positive results in the HRD population, but also in the all population. And these results give us the opportunity to use niraparib for patients, whatever is the results of the HRD test. We have also the SOLO-1 trial dedicated to patients with BRCA mutated tumor who also report huge results in this population with another ratio of 0.30 and give us the opportunity to use olaparib for BRCA mutated patient. And finally, the PAOLA-1 trial using olaparib plus bevacizumab versus bevacizumab alone in the ITT population, also reporting positive results and give us the opportunity to use this combination in the HRD positive population, including a BRCA mutated patient. There's three data report an increasing results in terms of PFS using a maintenance therapy with PARP inhibitor. And when we look at the long-term follow-up data, we see that, for example, with SOLO-1, a very long efficacy for olaparib, looking to the PFS. And also, we have seen the same results in the relapse setting using PARP inhibitor as niraparib or rucaparib. And for example, we can see on the slide the results of the NOVA trial in terms of overall survival, where we have seen also it is not statistically significant a benefit in PFS and overall survival for these patients. So in this SGO, we have seen new data in first line. And the first trial I would like to mention in the Ovarian phase 2 trial is a phase 2 dedicated to the use of niraparib and bevacizumab as a maintenance therapy in first line for patients in response to platinum-based plus bevacizumab treatment, whatever is the surgery, whatever is the residual disease. This trial used niraparib at 200 or 300 milligram plus bevacizumab 15 milligram kilo every 3 weeks. In this trial, the author report very good results in terms of PFS rates and median PFS in the ITT population. But as we can see on the slide, with a huge benefit in the HRD positive population using this combination with an overall survival rate of 23.8%, but also it is immature. The data are really encouraging, and the PFS analysis show a clinical benefit in the overall population and in the biomarker subgroup, with no new safety signal observed in this phase 2. We will come back on the safety later. The second important data report at the SGO is the phase 3 PRIM report by the Chinese group exploring the niraparib as a maintenance therapy alone in newly diagnosed advanced ovarian cancer. More than 380 patients were randomized to receive niraparib or placebo after partial or complete response to platinum-based chemotherapy. There is no BEV in this trial. The stratification factor used biomarker as GBRCA or non-GBRCA. An HRD score were used, reporting 66% of patients with an HRD positive test, and the primary endpoint is the PFS using the Beaker analysis. The results are positive in the ITT population with a median PFS of 24.8 months using the PARP inhibitor compared to only 8 months with the placebo. And as you can see on the slide, we see a positive effect in the whole subgroup, including GBRCA or non-GBRCA, deficient or proficient status, using neoadjuvant chemotherapy, or patient in partial or complete response at the end of the chemotherapy. So this trial report a PFS benefit in overall population and in all biomarker subgroup, with again no safety issue in this Asian population. The last trial, it is not in first line, but it is a very interesting trial using the niraparib and the enlotinib anti-angiogenic agent in the platinum-resistant ovarian cancer. In this phase 2 trial, including 40 patients using this combination of niraparib and enlotinib, the author report a huge response rate, 55% or 50% looking to the number of patients evaluated using this combination, with a long rate of stable disease also with this combination, and only 5% of the patients were in progressive disease at the time of the analysis. The median PFS is quite good, at least more than 8 months, and the safety is as we anticipate using this combination, with some hypertension but also on-foot syndrome, thrombocytopenia, and neutropenia. However, this combination of niraparib with enlotinib show promising anti-tumor activity with a safety profile quite acceptable in this population, and need more evaluation for the future. So in summary, the patient with ovarian cancer receiving niraparib maintenance therapy show an improvement in their outcome regardless of their genetic status. It is particularly right in the PRIME study. We have novel combination of niraparib with other agents showing promising results as a new treatment modality. However, we need more detail, longer follow-up to see what's happened in the future. And taking together all the data already available today, we have an overall benefit for patients to use a PARP inhibitor in first line, with greatest results in the HRD positive population compared to the HRD negative population. The second section is really dedicated to safety data on PARP inhibitor, what it is the news this year in 2022. As we have seen several side effect using PARP inhibitor, whatever is the niraparib, olaparib alone, or in combination with BEV. We have also seen the acceptability of this maintenance therapy in first line for 2 or 3 years, depending of the trial. However, we have not some fatigue, asthenia, nausea, anemia, thrombocytopenia. That means we need to be very careful, and would happen in the real life. It is one of the data report by Philip and colleagues about the quality of life of patients with advanced ovarian cancer. This paper look at the patient receiving or not receiving a PARP inhibitor in first line setting. We are not speaking about a randomized trial, but it is what's happened in routine practice. These patients are included in first line with whatever is the histology and the FIGO stage, but also in relapse. And when we look at the results all together, we see some interesting data in terms of quality of life. And if effectively the patient receiving a PARP inhibitor at the beginning of the maintenance therapy, just after surgery or after the end of the chemotherapy, have a lower quality of life score compared to patients who did not receive maintenance, when we are at 1 year, we see exactly the same quality of life for the patient receiving a treatment or patient with active surveillance. That it is a huge and important message to report to our patients. The other interesting trial is to look at the toxicity of the PARP inhibitor, looking to the BRCA and HRD status. Since long time, we anticipate that perhaps patients with a BRCA mutation, and more particularly a germline BRCA mutation, can be able to have more side effect than the other one. This is also a retrospective review of patients under PARP inhibitor since several years. And these data are really interesting to report that we did not see any huge toxicity in the GBRCA population compared to all the other molecular subgroup for the overall toxicity, but also for hematological toxicity and gastrointestinal toxicity. It is important data to report to our colleague. We don't see any difference in terms of side effect, whatever is the molecular subgroup. The other interesting data to report is about the combination of PARP inhibitor. We already know the results of the combination of olaparib with bevacizumab in the PAOLA-1 trial. The Ovario also report the safety results using niraparib and bevacizumab. And as you can see on the slide, also we see a little bit more treatment discontinuation with the combination compared to the monotherapy. It is consistent what we have seen with other trial. And at the end, we don't see a side effect able to consider that the combination will be an issue for the patient. Finally, what about the safety profile of the niraparib in the ASEAN population? The PRIME phase 3 trial did not report again any safety signal using niraparib in this population. The discontinuation rate is very small compared to what we have seen in the Caucasian population. We have perhaps some interruption and dose reduction, but nothing to be important. And at the end, we don't have so huge difficulty in terms of myelodysplasia or leukemia, only 2 cases in this phase 3 trial. So in terms of summary, the real world evidence suggests that patients with advanced ovarian cancer receiving PARP inhibitor in first line may initially have a reduced quality of life, but it is improved over time. Patient genetic status does not appear to impact on the toxicity on the PARP therapy, and clinical trial investigating diraparib alone or in combination report manageable safety profile. Now moving about the data, we will be able to personalize our first-line maintenance therapy in ovarian cancer. As we have seen in the past, we know that there is a lot of prognostic factor able to explain the progression-free survival and also the overall survival in terms of clinical factor as age, FIGO stage. Some years ago, we have anticipated that BRCA status is also something important to consider for the prognostic of our patient in routine practice, but also in our clinical trial. And this paper report by Sims and colleagues also explore how the HRD status could be important to explain the prognostic of our patient. And it is exactly what they report in this retrospective analysis. Using a Cox model, they also confirm that FIGO stage, age, quality of the surgery is an important prognostic factor to explain the survival of our patient, but also the HRD test. And now we need to know the BRCA status, but also the HRD test to understand the prognostic of our patient to decide about the treatment, but also to explain what will be the prognostic of the patient. Another important point to understand the efficacy of the PARP inhibitor and to understand what could be the best candidate for PARP inhibitor is to look at the short and long-term PFS in the population of patients receiving a PARP inhibitor. It is exactly what Stéphanie Lheureux have done with the opinion study, exploring the group of patients with a short-term PFS less than 4 months or a long-term PFS less than more than 18 months. In this study, they report that clearly the HRD positive status and the BRCA status explain the difference between the patient we have a long-term PFS versus a short-term PFS. Another factor reported by Stéphanie is also the quality of the response to platinum-based chemotherapy, and we have seen that the patient with partial response to platinum-based chemotherapy have a small PFS, short PFS compared to the patient with complete response. It is important to understand the results of our clinical trial, but also how to decide in terms of maintenance therapy. Another important topic is the HRD test. We have seen with Paola, but also with Prima, how it is important to understand the HRD status for our patient to identify the best candidates for a PARP inhibitor or to decide to use the BEV alone and or the combination. Using the tumor sample from Paola 1 trial, the Leuven group decide to confirm the quality of an HRD test developed at the local level using NGS platform and copy number single SNP using also BRCA and some gene mutation. In this retrospective post-hoc analysis, they report two important things. First, this is the first academic HRD test report to be similar to the myriad my choice results in terms of positive and negative agreement, with an overall agreement of 91%. And when we look at the results with the validation of the clinical data, we also see the same hazard ratio and median PFS using a PARP inhibitor plus BEV versus BEV alone that we have seen with the myriad my choice, considering that the Leuven HRD test reports similar impact of olaparib on PFS as we have seen with the standard myriad my choice plus test, that it is something really important. We have the possibility to validate new tests and to have these tests available for the future for routine practice. The last but not so much important topic is about the cost efficiency of this test. We have understand that the test is able to report and to identify the base candidate for PARP inhibitor, but it is also something interesting to look at the society level. And when we see this analysis integrating the cost of the HRD test in the different maintenance therapy using olaparib alone, using niraparib alone, the combination of olaparib plus BEV or BEV alone, we see that using the test, we are able to identify the best candidate, but also to report the most interesting results in terms of PFS and so quality to identify the best treatment for our patient. So in the real life, we have seen that we have now several different maintenance therapy available using a BEV alone, using PARP alone, using the combination. And this trial report by Cathy Moore, it's not a trial, sorry, it's a study, a retrospective study about the real life use, we have seen some interesting data comparing the US center and European country in terms of using BEV or not using BEV. This analysis take place in 2017 to 2020. So we don't have enough PARP inhibitor in all country, but we have seen a huge use of PARP inhibitor in US compared to Europe. And what it is interesting is that we have seen more and more maintenance therapy delivered to patients in first line setting since 2017, that it is an important topic because this disease unfortunately have a poor prognostic and need maintenance therapy in first line. Another real life study report by Liu and colleagues about the use of PARP inhibitor in first line is coming from more than 1,000 patients from US. We have seen the use of PARP inhibitor or BEV or active surveillance. Unfortunately, we see that some patients continue to receive active surveillance. Also, we have seen very good results using maintenance therapy in first line. And this paper report that unfortunately the use of maintenance therapy is not completely homogeneous in US, and we have seen that there is some difference between academic and community institution. We have also seen that the BRCA status is not always available, and this is something important, and also the number of cycle of chemotherapy. We need to improve our routine practice also in first line ovarian cancer. Another interesting data about the use of niraparib report again by Liu and colleague is that also we have seen very good results using the individual dose with niraparib for patients with less than 77 kilogram or platelet counts. We see that unfortunately 25% of ovarian cancer patients eligible for individual dose did not receive individual dose. This is something important. We need to do our best for the patient in terms of efficacy, but also in terms of safety. So in summary, the real-world evidence confirmed that frontline PARP inhibitor maintenance is now on board and need to be used for our patient. BRCA mutation and HRD tumor status are good biomarker to identify the best candidates for first-line maintenance PARP inhibitor. And PARP inhibitor in monotherapy or in combination with BEV are not used similarly in the different countries, something important for the future trial. Thank you very much for your attention.
Hello, my name is Dr. Antonio González Martin. I am medical oncologist and cancer center director of the Clínica Universidad de Navarra in Madrid, Spain. I am also the chair of the JACO group. It's my pleasure to be today here sharing with you some thoughts about the SGO 2022 and how is the new information about the PARP inhibitor use in the front line of advanced ovarian cancer. So the first thing I would like to share with you is that this meeting has already confirmed the data of niraparib in the front line. There are a couple of studies that I would like to highlight. The first was the Ovario trial. The Ovario is a phase 2 trial of the combination of niraparib and bevacizumab as maintenance in newly diagnosed patients with advanced ovarian cancer, regardless of the biomarker status. This trial have already presented data before with a progression-free survival rate at 18 months, but now they have presented the progression-free survival at 24 months Interestingly, the more than half of the patients, 53% of the patients, remain progression-free at 24 months. It's also remarkable the median progression-free survival of 19.6 months. This is a phase 2 trial with 105 patients that included mainly patients with high-risk ovarian cancer, but somehow has demonstrated the efficacy of this combination. But the most important study is the PRIME study. This is a phase 3 study replicating the PRIMA study, but in the Chinese population. Patients with advanced ovarian cancer have been randomized to niraparib or placebo as maintenance therapy after frontline therapy. There are a couple of remarkable differences with PRIMA. First, patients with complete cytoreduction and stage 3 were included in this trial. And second, the individualized starting dose was used for all the patients. This trial is positive for the intent to treat population with a median progression-free survival of 24 months in the niraparib arm and 8.3 months in the placebo arm, and has a ratio of 0.45. Importantly, the subgroup analysis according to the G-BRCA mutation, the HRD status, the use of neoadjuvant chemotherapy, or the response to first-line chemotherapy were all in favor of niraparib. So, in summary, I think that SGO-22 has confirmed the extremely benefit of niraparib as maintenance in frontline ovarian cancer in all the subgroup of patients. There are a couple of or two or three important messages from SGO 2022. First, a poster presented by Dr. Bild with more than 200 patients tried to correlate the safety of the PARP inhibitors in women according to the biomarker status, and it was confirmed something that we knew, that is that the status of G-BRCA or the HRD does not affect the overall toxicity, the gastrointestinal toxicity, or the hematological toxicity. But in terms of safety, I would like to highlight again a couple of studies. The first is the Ovarian study. I mentioned before is the combination of niraparib and bevacizumab in the front line as maintenance after frontline chemotherapy in advanced ovarian cancer. So importantly, the discontinuation rate in this ovarian study with niraparib and bevacizumab was 22%, which is very similar to the discontinuation rate in the Paola-1 trial, indicating that combination therapy versus monotherapy is associated to higher rate of discontinuation. The second trial that has informed about the safety management of PARP inhibitors in frontline is the PRIME study. As I said before, PRIME is the replicate of PRIMA in the Chinese population. Importantly, the rate of discontinuation in this study was only 6.7% and very similar to placebo. And I would like to remind that all the patients had started with the individualized starting dose. This is remarkable because again has confirmed that single agent PARP inhibitor induce a lesser rate of discontinuations. In terms of those reductions or this or treatment interruption, it was also observed a reduced number in comparison with the PRIMA study. Globally speaking, there were no new safety signals with niraparib in this trial. The most frequent treatment emergent adverse events were hematological and gastrointestinal events. And as I said, nothing new in comparison with PRIMA, but the rate of grade 3 or 4 hematological toxicity was lower than in PRIMA. In conclusion, the PRIME study has confirmed prospectively again that the individualized starting dose is associated to a lower rate of hematological toxicity, to a lower rate of treatment discontinuation, dose reduction, and treatment interruption. And the question is completely no. In the other way, SGO 2022 has confirmed how important it is to personalize treatment according to molecular characteristics. There are three things I would like to share with you. First is a retrospective study of a single institution using PARP inhibitors as maintenance in frontline or recurrent setting. And they have confirmed something that we already know. This is the poster presented by Sims, and they have shown that patients with GBRCA or somatic BRCA or HRD do have a better outcome with the PARP inhibitor. It's something very well known. The other piece of information that have produced SGO 2022 is a sub-analysis of the molecular characteristics of patients included in the opinion study and trying to associate these molecular characteristics to the duration of progression-free survival. Opinion was a trial with olaparib as maintenance therapy after response to platinum rechallenge in the recurrent setting, and they have observed that those patients with longer progression-free survival, median longer than 18 months, are predominantly patients with HRD positive tumors. But in my humble opinion, the most important work presented in this SGO meeting regarding the molecular testing is the HRD University of Leuven testing. I would like to introduce that at the end of the Paola 1 study, samples from 468 patients were able to be analyzed with different platforms from the Myriad My Choice platform. That was an initiative seeking for a reliable and academic HRD platform for HRD testing. In this meeting, the group of the University of Leuven have presented their platform. A couple of important things are concluded. First is that the rate of agreement is very high between Myriad My Choice and the Leuven University platform. And the second important message is that the predictive value of this platform is remarkable similar to the Myriad My Choice. There are no differences in the differentiation of patients obtaining benefit. So as conclusion of this SGO 2022 meeting, I think that we are in the right direction, testing for BRCA HRD status of our patients, and probably in the near future we will have new platforms that can be complementary or substitutes to the immediate My Choice. So I would like to highlight one interesting paper presented by Dr. Joyce Liu that is a real-world evidence of the use of PARP inhibitors in first line as maintenance among patients with advanced ovarian cancer. They included the study of 1,010 patients, which data were obtained from Flatiron Health Electronic Health Record Derived database. They identified patients with stage 3 and 4 epithelial ovarian cancer that have received either first-line maintenance therapy or active surveillance. Importantly, the active surveillance was selected by 62% in 62% of patients. So one of the main conclusions is that we still have room for improvement in order to the implementation of maintenance in frontline. Regarding the sort of maintenance therapy used in first line, 42% of patients receive PARP inhibitor alone, 40% of patients receive bevacizumab alone, and the combination of bevacizumab and PARP inhibitor was used by 88% of patients. When they have analyzed the predictors for the use of PARP inhibitor monotherapy in the group of patients that received maintenance in frontline, they observed that it was more frequent in the community than in the academic setting. It was much more frequent for patients with BRCA mutation than patients that do not have a BRCA mutation. And the other important thing that they have seen is that the use of PARP inhibitor as monotherapy has been increasing significantly from the year 2018 to 2020. So, in conclusion, this important real-world evidence study has indicated a couple of things. First, that the number of patients still receiving active surveillance is higher than 50%. And second, that probably this will change in the future as the increment in the use of PARP inhibitor was increasing from 2018 to 2020, and it was more frequent in the community setting and also in the BRCA mutated patients. So my impression is that the use of PARP inhibitors will increase significantly in the next 5 years. That is not only an opinion, it is based on data. I have participated in a trial that was called Royal Trial, that is a real-world chart review analysis of more than 7,000 patients from UK, Italy, France, Germany, Spain, and the United States. 5,386 patients had stage 3 and 4. They were analyzed in 3 different cohort of times from June 2017 to May 2020. What we have analyzed in these more than 5,000 patients was the use of first-line maintenance therapy. And globally speaking, although there are some differences between the countries, but globally speaking, the use of first-line maintenance has increased from roughly 50% in 2017 to approximately 65 to 70% in 2020. And obviously the rate of surveillance has decreased. In terms of the sort of treatment, what we have seen is that in the BRCA mutated patient, there was a clear decrement in the use of bevacizumab in frontline and a dramatic increment in the use of PARP inhibitor as maintenance in frontline. Actually, in the cohort 3 that belongs to the period from June 2019 to May 2020, the use of PARP inhibitors in BRCA mutated was 65 to 70%, but the use of bevacizumab was roughly over 20%. And importantly, the combination is still under use with only 10%. In the BRCA wild type group of patients, we also have seen decrement in the use of bevacizumab, and it has we have also observed a slightly increment in the use of PARP inhibitors. So what I foresee for the future, and based on these data, based on my own experience, is that in the future we will incorporate more and more PARP inhibitors to the first line, specifically for the BRCA mutated patients, but also for the non-BRCA mutated patients.
Yes, hello to everyone. My name is Sandro Pignata. I'm a medical oncologist and I'm the director of the oncology unit in the Department of Urology and Gynecology at National Cancer Institute of Naples. I think in this year at SGO, several data have been presented that are very interesting in the field of PARP maintenance in first-line treatment. I think a couple of these trials presented merit more discussion. First, the Ovario trial has been the first investigating the combination of niraparib and bevacizumab. You know that in the past, the data of the PALA-1 trial with the combination of olaparib and bev have been presented. Now we have also data from the combination of niraparib and bev. These data are very interesting and support the fact that the combination of PARP and anti-androgenetic could be effective in ovarian cancer. However, even in this case, as in PALA-1, we do not have a single arm with bevacizumab alone. So we cannot be sure of the synergistic effect of the two drugs. Another important trial that I want to comment is the PRIME trial, a trial that has repeated the experience of the PRIMA trial in first-line ovarian cancer, but with some important differences, because in this trial, also patients with complete cytoreduction of primary surgery have been included. Well, in this trial, we saw interesting results with a significant impact on PFS of the addition of niraparib maintenance after chemotherapy. And this is of note, on my point of view, that a significant and clinically relevant increase in PFS was observed also in the cohort of patients with HR proficient tumors. Again, even considering the question of the safety of the first line maintenance with PARP, we have at SGO important data. The same trial I have discussed before, Ovario, with the combination of niraparib and bevacizumab, confirm that adding an anti-androgenic drug to the PARP inhibitors increase the toxicity, and in particular of note is the presence of 25% of the patients experiencing G3 and G4 hypertension. And we have another small trial presented here with niraparib and a TKI inhibitor that is called anlotinib, but the same proof of concept, PARP and anti-angiogenic. Even in this case, the toxicity is higher than with the PARP alone, even if in this case the treatment was given to platinum-resistant patients, so in a different setting. Other information come again from the PRIME trial. The PRIME trial, compared to the PRIMA trial, had all patients randomized and with niraparib dosing according to platelet counts and weight of the patient. So what is now considered standard in the general practice, based on the radar analysis of the NOVA trial. In this case, using this adapted dose, in this trial, there was a significantly lower level of thrombocytopenia, G3, G4, that was only 17%, and also of anemia and neutropenia. This means that this adaptation of the dose can help to spare a lot of toxicity to our patients. I think we are all convinced today that the best activity of the PARP inhibition is in the patients that carry a BRCA mutation. From this SGO, I think there is a confirmation of this fact, and there is also evidence that the patients with HR deficient tumors may benefit more than those that are proficient. So several studies have demonstrated this. So I think it becomes very important to test the homologous recombination status in the clinical practice. What in this moment doesn't occur, for example, in my country, but I suppose in the majority of the countries worldwide. On the other hand, it's very important to test the patients for HIV deficiency because we also know from the data presented at SGO that the HRD deficient status is prognostic of a better prognosis and predictive of a better response to therapy. In this context, it has been presented for the first time at SGO this year the first results of a project conducted within a Paula 1 consortium in Europe, trying to evaluate the effectiveness of academic tests for homologous recombination. The first test has been presented from the group of Leuven in Belgium that strongly correlate with the results of the Myriad test, that is the standard and the test used in all the pivotal trials, thus suggesting that it will be possible in the future to use academic testing to increase the knowledge of this important factor in the majority of the patients. As usual, when a new class of drugs is introduced in the clinical practice, the main question is how the results obtained in the randomized registration trial in patients that are super selected for the inclusion criteria that are typical of the trials are the same in the context of the real life general practice. Our patients in general practice are completely different from those that enter the clinical trials. But at this SGO, several real world experiences have been presented, showing two important things in my view. The first is that the number of patients that receive PARP inhibition is increasing over time. At the first couple of years, the majority of the patients treated with PARP was those patients carrying a BRCA mutation. Now it is clear worldwide that it's useful to treat also patients beyond BRCA that can benefit from the treatment. And I have to say that the data presented here support the fact that the safety is similar to those recorded in the registration trial, and that, as expected, the patients that benefit more are those with BRCA mutation, but the benefit is extended to all the categories of patients with high-grade ovarian cancer. Well, what I expect from the data that will be produced in next years, that we will be able to better understand the biology of the patients we treat with PARP inhibition. In particular, I think there are two main topics that need our attention. The first is to try to understand which are the patients that we consider long responders to PARP inhibition. We still don't know. Even in this SGO Congress, the data of the opinion trial in the recurrence with the patient non-mutated receiving olaparib have not clarified who are the patients that benefit for a longer time. I think this is very important, and we need to better understand the molecular biology of this cancer. The second is that we need to go further to HRD. HRD is prognosis, is somehow predictive, but we need more molecular factors that can predict the response to PARP inhibition. And I think a number of groups worldwide, including ours, is working on this aspect. Another point that I would like to discuss is what we expect from the trials that are ongoing. I think the main question for which we want to see, and we will see the results very soon, is what means to combine PARP inhibitors and immunotherapy checkpoint inhibitors. We have several trials that have completed the accrual. I think in the next 2 years we will have the answer to this important question.
Hello, my name is Professor Isabelle Recoca, medical oncologist at the Centre Léon Bérard and professor at the University Claude Bernard Lyon in France. At the SGO this year, we have seen using the niraparib alone in the phase 3 report with the PRIM results, or in combination with BEV with the Ovarian phase 2 trial, that PARP inhibitor in first line works very well alone or in combination, and this increase our knowledge about the efficacy of PARP inhibitor and reinforce our decision to implement PARP inhibitor in first line. It is an important topic. We now use PARP inhibitor in first line, so we need to educate ourselves, but also the patient, because the compliance is something important as it is an oral treatment. It is much more easier when we are speaking about IV treatment, where the nurses is doing the job and the patient is coming only every 3 weeks. For oral treatment, we need to be sure that the patient will not be alone with side effect, and in the other end we would like to be sure that he is taking the drug every day as it is recommended by the randomized trial. And this year at the SGO, we have seen that the safety profile of this drug in different new clinical trial or in routine practice is safe, and we don't see any adverse events not able to be managed using the reduction of the dose or using some symptomatic treatment. So it's something important. We have seen also that if we have some decrease in terms of quality of life at the beginning of the treatment, at 1 year, we don't see any difference between the patient receiving PARP inhibitor or nothing, that it is something important to remember. For the first time in ovarian cancer, we have choice. We have the possibility to personalize the maintenance therapy, and it is something really important for us, but also for the patient. And we have seen with Paola and Prima how the HRD test is important for our patient to decide about the maintenance therapy, what is the best maintenance therapy, PARP alone, PARP in combination with BEV, BEV alone. And the second point is we have seen with the SGO that HRD test is a prognostic factor able to explain the risk of relapse of our patient. Something important to report to our patient, something important for the future clinical trial, and also to be able to mention to our patient what is the magnitude of the efficacy of our treatment we would like to propose to them in routine practice. At the SGO this year, we have seen several retrospective analyses about the use of maintenance therapy in first line in the different country and also in US. We have seen some interesting data. Also, the Royal study was conducted before a full agreement of PARP inhibitor in Europe, but we have seen really a huge use of PARP inhibitor in US compared to the use of BEV plus or less PARP in Europe, for example. The good point is we have seen that more and more patients receive maintenance therapy over the world, that it is something important because again, this disease is not breast cancer, is a really poor prognostic disease when we have an advanced ovarian cancer. And we have seen more and more patients receiving PARP inhibitor, that it is also a good news for the patient. We have also seen that in terms of niraparib use, something important to report. Also, we have now the individual dose schedule. We see that unfortunately 25% of the patients did not receive the individual dose. We need to educate our colleagues and our patients. In fact, there is different point to explore. We know that there is currently a clinical trial in east part of Europe and Asia dedicated to olaparib beyond BRCA alone and not in combination with BEV. And it will be interesting to make the comparison with the Paola one reporting the efficacy of olaparib in the ITT population, but in combination with BEV. The other combination interesting to explore will be the use of PARP inhibitor plus or less BEV with other immune checkpoint inhibitor, and we will be really interested to see the result of the first trial using dostarlimab in the future. There is also other trial using other immune checkpoint inhibitor as a duo trial, the NGOT OV43. Another interesting question will be about the use of rucaparib in first line, and we know that Athena trial exploring rucaparib alone will be available this year. It's interesting to have another option for our patient. The other question is about the specific population, what we can do for the HRD negative population where PARP alone or the combination with other drug could be interesting, or completely different management of this patient. We need to do something for the HRD negative population who are the poor prognostic subgroup. What about the population could be curable? Patient with upfront surgery, no residual disease, stage 3. We have seen with Paula 1 this patient with 90% of progression-free survival at 2 years. It is a population where we are able to cure this patient. What about early stage? We use chemotherapy for stage 1 and 2. Is there a place for PARP inhibitor in this setting? Is a really important question for the future. The duration of the maintenance therapy, we have the possibility to use 2 years with the olaparib or 3 years with niraparib. What could be the best duration of treatment, looking to the fact that these drugs are efficient in first line? And the last point is about the overall survival. It is important to see what's happened in terms of overall survival. And I'm really pleased to inform that the results of the overall survival of Paula 1 will be available this year at ESMO 2022. Thank you very much.